We do have time for a couple of questions, so I'm going to try to get as many answers as I can. So let me ask both of you, for a 55-year-old with an ITD, which FLT3 inhibitor would you choose, and would there be any strong evidence in favor of one over the other?
Okay, I think that at the moment, I don't have any particular preference because the two were included in trials. Ratify was up to the age of 59, and Quantum First had no apparent limit until I think was 70 years or even more, and we have to consider maybe toxicities. For example, cutaneous skin toxicity, I think, is higher with midostaurin, and the other toxicities, I think, are quite similar. So at the moment, and in the absence of head-to-head comparisons, my personal view is that I don't have a preference.
You know, in general, I agree with Jorge Sierra. You know, there's no real comparison, so either one you choose is fine. I'm a little bit more inclined to use quizartinib more frequently. Mostly the adverse event profile seems to be, you know, I see less cutaneous GI toxicity, etc. But you know, sometimes you know, midostaurin is what we have, and I'm perfectly happy. I don't think there's any clear way to differentiate the two in terms of the efficacy and the outcomes. You know, the studies look very similar, and we would love to see that direct comparison, but probably never going to happen.
Fair. I'm going to take a first crack at the next one, and then you guys jump in. So does FLT3 MRD after cycle 2 inform transplant decision in CR1 currently? So, I mean, I think that is a really, really big point. And I can tell you, we have patients coming in for that discussion. We do have access to the high sensitivity assays, and it's hard because nobody really feels like going through a transplant if they don't have to. But at the same time, I would argue that currently, you know, monitoring carefully doesn't cure you of disease. It monitors. And I think what we don't know is whether or not those patients can, if you have a very healthy 40-year-old with a good donor, are you going to rely on the MRD data not to transplant that patient? I can say that personally, it is influencing transplant decisions, especially if there are reasons where I'm unhappy to do a transplant, either biological ones, medical ones, clinical ones, social ones. If I would love not to be doing a transplant on a patient and I have someone who is completely negative, I am considering that strongly. But if I have a very, very strong, excellent patient with a strong, excellent transplant, I am nervous about changing practice just yet. Do either of you have something that you would like to disagree or add to that comment on MRD-guided transplant decisions?
Well, I do, you know, I generally agree with you, but I think one thing that you mentioned in your presentation that's important to emphasize is the quality of the MRD testing, because an optimal MRD results with a suboptimal test is not equal to confidence. So if I don't have that access to that MRD level of measuring, I'll say I'm going to transplant my patient. I'm going to be glad to see it negative, but I'm going to go with the transplant. If I have that level of confidence, if I can do it well, then yes, I may skip the transplant, especially as you mentioned, if there is any concern about the suitability or comorbidities or anything.
I really think that we must emphasize again the testing and the different times of the different tests are incredibly, incredibly important and get incredibly confused. Flow cytometry-based MRD monitoring is not what you want to be doing for NPM1 mutated patients, for FLT3 mutated patients. It's not okay to say, well, I don't have the assay, therefore I'm only going to use flow. It's perfectly the case that people around the world may not have access to the assay, but the decision-making of what you're going to do is very, very dependent on that assay. And I will use this as a final 2-second comment that the ELN we have on the MRD committee recently updated the guidelines for MRD monitoring, including all of these new and very important data regarding NPM1 and FLT3 with a lot of specificity for clinicians in the new guideline, which was accepted and will be published hopefully soon, to allow clinicians to really figure out what they have access to, do they have the test, and how to make the decision-making based on it. But we should not end this webinar with killing transplant and FLT3 mutated AML, far from it. That's how we are still curing a lot of patients. I want to thank you guys very much for your participation. Thank the organizers. Thank everybody for the very positive comments that are already coming through. We appreciate that, and we look forward to many more successful webinars. Thank you so much.
Thank
Thank you all.